Okay, let's dive into this. Picture this. You're suddenly awake, middle of the night, right? And your little one is there clutching their ear, crying. It's that feeling, you know? Tonight, we're tackling that classic childhood issue, acute otitis media, SOM. Think of this as like your quick guide to understanding these really common ear infections.
Exactly. We've gone through the revision notes, pulled out the key stuff on AOM for you. The mission, really, is just to give you a clear, high-yield picture, cut through the jargon.
Yeah, get straight to the point.
Right. So you walk away knowing, okay, what is AOM? Why does it happen? How do you spot it? And what do we usually do about it?
Perfect. So let's start right there. Acute otitis media. What exactly are we talking about?
Okay, so simply put, AOM is a sudden inflammation, an acute inflammation of the middle ear. That's the bit right behind the eardrum. Now, the notes mention other related things you might hear about, like otitis media with effusion that's glue ear, basically fluid without the acute infection. Then there's chronic suppurative otitis media, mastoiditis, cholesteatoma. But with AOM, the key word is acute. It happens fast.
Acute inflammation.
Yeah. And it's usually caused by, bacteria or viruses, super common in kids. Oh, and in about maybe 5% of cases, the eardrum can actually perforate, burst.
Yeah.
That's called acute suppurative OM.
Bacteria and viruses,
Yeah.
the usual suspects for kids' illnesses, right? So who are the main players here, the specific bacteria and viruses?
Yeah, so for bacteria, the main three you need to know are Streptococcus pneumonia, often just called pneumococcus Haemophilus influenza.
That's not the flu virus, though.
No, different thing. H-flu, we sometimes call it,
Yeah.
and Moraxella catarrhalis. Those are the top three bacteria.
Okay.
And for viruses, respiratory syncytial virus, RSV, that's a big one, and the different influenza viruses that do the rounds every year.
Right, got it. So we know what it is, who causes it. Now, who's most likely to get AOM? What puts some kids more at risk?
Well, there are quite a few risk factors. Generally, younger kids are more prone, partly just because their immune systems are still getting up to speed.
Makes sense.
Exposure to secondhand smoke is definitely a big factor. And being in places like daycare or school where germs spread easily, that increases the risk too.
Yeah.
Family history can play a part if ear infections run in the family.
Mm-hmm.
And also, sometimes differences in how the head and face are formed, craniofacial abnormalities, if they affect how the eustachian tube drains, that can make AOM more likely.
Are there any, really specific risk factors that stand out in the notes?
Yeah, drilling down a bit, younger age is key, definitely. Being male seems to slightly increase the risk. Household smoking, as we said, daycare or nursery attendance is a big one.
Right.
And feeding method actually matters. Formula feeding is linked to a higher risk, whereas breastfeeding, especially for 3 months or more, seems to offer some protection. And then those specific craniofacial issues, like Down syndrome or a cleft palate, they significantly up the chances of getting AOM.
That's a really useful list. What about those kids who just seem to get one ear infection after another? Any specific triggers for recurrent AOM?
Absolutely. If a child has their very first ear infection really young, that unfortunately makes them more likely to get more.
Ah, okay.
Also things like gastroesophageal reflux disease, URTI, using a pacifier or dummy, the winter season obviously because of all the colds.
Yeah.
And even feeding a baby while they're lying flat on their back, supine feeding, that can contribute to recurrent AOM too.
Supine feeding, that's one parents might not always think about. Okay, so we've got the who and some of the why. Let's get into the mechanics. What's actually happening in the ear, the pathophysiology?
Right, so this all comes down to the eustachian tube. It's that little tube connecting the middle ear to the back of the throat, the nasopharynx. And basically, AOM often starts when this tube gets blocked or just isn't working right. Think of it like a tiny drain pipe. If it gets clogged, fluid builds up behind the eardrum.
And that trapped fluid is where the trouble starts, like a breeding ground.
Exactly. Perfect place for those bacteria and viruses we mentioned to will have a party. They multiply, cause inflammation, and that causes the pressure and the pain.
Right.
And kids get this more often because their eustachian tube is different from an adult's rough. It's shorter and it's more horizontal.
Ah, okay, so it's easier for bugs to get in.
Precisely. Easier for infections from the nose and throat, like from a common cold, to travel right up into the middle ear. The notes really highlight that link. AOM often pops up right after an upper respiratory infection.
Makes sense.
And we mentioned the main bacteria, but it's interesting. In maybe 30% of cases, they don't actually find a specific bacterial cause. And the notes also mention the usual viruses, RSV, rhinovirus. And quite surprisingly, SARS-CoV-2 was found in the middle ears of some people who passed away, even if they hadn't had AOM symptoms before. This sort of makes you think, doesn't it, how infections can pop up in unexpected places.
Wow, yeah, the SARS-CoV-2 thing is definitely unexpected. Okay, so if a child has ear pain, it's not always AOM. How do doctors tell it apart from other things? What are the differentials?
That's a really important question.
Yeah.
Yeah, lots of things can cause ear pain. There's otitis media with effusion, the glue ear fluid, but no acute infection signs.
Right.
Otitis externa, that's swimmer's ear, infection of the outer ear canal, painful when you touch the ear. Even just a cold can make the eardrum look a bit red sometimes.
Okay.
Then there's referred pain, maybe from teeth problems. That's quite common. Less common things like a herpes infection in the ear, something stuck in the ear canal like a bead.
Oh, yeah.
Pain from the jaw joint, the TMJ trauma to the ear.
That's quite a list already. Anything else?
Yep. Also need to think about chronic suppurative otitis media. That's the persistent discharge from a perforated eardrum, going on for weeks. And cholesteatoma, that skin growth in the middle ear.
Okay.
And finally, bullous meningitis, rarer. You see blisters on the eardrum, often linked to mycoplasma. But, the big clues pointing strongly towards AOM are a really red, angry-looking eardrum, especially if it's bulging outwards and the child is clearly unwell with a fever and just miserable.
Right, the whole picture. That helps narrow it down. So how common is this? What's the epidemiology look like?
Oh, it's incredibly common. The notes say over 2/3 of kids, so more than 2 out of 3, get AOM at least once by the time they're 3 years old.
Wow, that's huge.
Yeah. Peak age is around 6 to 15 months. It gets less common as they get older, but still over 75% of cases are in kids under 10.
And does it happen more at certain times of the year?
Definitely. More common in winter.
Hmm.
Which makes sense, right?
Yeah.
Because it often follows those winter colds and viruses.
Yeah.
There's also a slight tendency for boys to get it a bit more often than girls. And it's a big deal globally, especially in developing countries.
How big a deal?
Well, the estimate is around 10% incidence globally each year. That's over 700 million cases, and half of those are in kids under 5.
700 million.
Yeah. And the difference between low-income and high-income countries is stark. The rate can be more than 10 times higher in low-income settings, probably due to things like access to healthcare, nutrition, living conditions.
That really highlights the disparity. What about outcomes? Does it often lead to chronic problems?
Well, that chronic suppurative otitis media we mentioned, that develops in maybe 5% of AOM cases. And while serious complications are rare here, the notes have a sobering statistic. Globally, around 33 deaths per 10 million people are thought to be from OM complications.
Wow.
And most of those deaths, sadly, are in babies under 1 year old, mainly in developing nations.
That really underscores why understanding AOM is so important. So what are the classic signs and symptoms? What should parents or caregivers be looking out for? The clinical features.
Okay, so the symptoms. Ear pain otalgia is the big one. Young kids might pull at their ear, be really irritable, cry more than usual. You might see poor feeding, restlessness, a fever. Maybe they don't seem to hear as well. If the eardrum bursts, you might see fluid draining from the ear.
Okay.
Some kids might complain of their ear feeling full or blocked up.
Yeah.
And occasionally things like vomiting or disturbed sleep can happen too.
And what signs would a doctor or nurse be looking for when they examine the ear?
Key things are a high fever, and when they look with the otoscope, the eardrum, the tympanic membrane looks red, cloudy, and it's bulging outwards. Sometimes you can even see a line behind it, an air fluid level.
Right.
If it's perforated, you'll see discharge, plus maybe in the ear canal. The outer ear might look a bit red too, sometimes. One thing to remember, though, is that in really young infants, under 6 months, the symptoms can be quite vague, nonspecific.
Harder to tell.
Yeah. And interestingly, if the eardrum does perforate, that release of pressure can actually make the pain better, temporarily at least.
Ah, okay, that makes sense. So pulling it all together, what are the key pointers for diagnosing AOM?
You're looking for that combination? The risk factors we talked about, young age, daycare, smoke exposure. Then the symptoms, the ear pain, maybe reduced hearing, often with cold symptoms like a runny nose, what we call coryza, irritability, fever.
Right.
And then the crucial finding on examination, that bulging red opaque eardrum. If you see pus or scarring, that suggests a perforation, either now or in the past.
Okay, so it really sounds like the diagnosis is mostly clinical, based on symptoms and the ear exam. Are tests usually needed? Investigations?
Yeah, the notes are pretty clear. For straightforward AOM, diagnosis is clinical. You generally don't need extra tests.
That's a no.
But there are exceptions. If a child has repeated perforations or chronic discharge, or if they have grommets in place.
Those little tubes.
Yeah, the ventilation tubes. Then a swab of the discharge might be sent for culture to see exactly which bacteria are causing the trouble. Hearing tests, audiometry, that's more for checking long-term hearing loss, not usually done during the acute infection.
On scans.
Scans like CT or MRI, only really if there's a worry about serious complications spreading beyond the end.
Okay, so usually no tests needed. What about treatment then? What's the typical management plan?
Right, so for milder cases, the focus is often on pain relief first and foremost. Supportive care, fluids, rest, and watching closely. Antibiotics aren't always the first step.
Really?
Yeah, the decision depends on how severe the symptoms are, the child's age, other risk factors. You can get ear drops with anesthetic or painkiller in them, which can help numb the ear directly. And the advice is usually to reassess if things aren't better in, say, 7 days or so.
Okay. So when are antibiotics typically used?
Well, the key thing the notes stress is that many, maybe even most AOM cases get better on their own. So we try to avoid giving antibiotics routinely, especially for mild or moderate infections, or in kids under 2 if the diagnosis isn't absolutely certain. We want to avoid unnecessary antibiotic use.
Makes sense, resistance and all that.
Exactly. But if antibiotics are needed, the usual first choice is amoxicillin, typically for 5 days. If there's a penicillin allergy, there are alternatives.
Okay.
And if the child starts amoxicillin but gets worse or doesn't improve, then sometimes a broader antibiotic like comoxiclav is used, maybe for 5 to 7 days.
What about things like antihistamines or decongestants? You see those advertised for colds. Do they help AOM?
Nope. The evidence just isn't there. Antihistamines, decongestants, they don't seem to help with AOM itself. Same goes for echinacea. No proven benefit. A simple warm compress on the ear might feel soothing, though.
Good old-fashioned comfort measures. When should parents worry or seek more help, maybe even see a specialist?
Definitely seek more advice if the symptoms aren't improving after a few days or if they seem to be getting worse, even with treatment. Hospital admission might be needed if the child is very unwell, developing complications, or has a really high fever they can't control.
Right.
And referral to an ENT specialist. That's usually considered for kids who get recurrent AOM, especially if it's causing hearing problems or complications or the symptoms just drag on. But the notes are quite firm. Long-term preventative antibiotics are generally discouraged.
Okay, so just to recap the main points on management. Pain relief first, paracetamol, ibuprofen, maybe delayed antibiotics sometimes.
Yeah, sometimes a doctor might give a prescription but advise waiting 2-3 days to see if things improve with just pain relief. And the antibiotic choice, usually amoxicillin first line, follows local guidelines.
Gotcha. And you mentioned something called tympanocentesis.
Ah, yeah, that's more specialized. It's where they use a fine needle to drain fluid from behind the eardrum. It might be done in hospital for really severe pain or if infections aren't responding to antibiotics, but it's not routine.
Okay, clear. So we've covered diagnosis and management. What's the usual outcome? The prognosis.
Generally, it's really good. Most kids with AOM get completely better within a week or so, sometimes even without antibiotics.
That's reassuring.
Yeah, but as we've said, those kids with recurrent or chronic problems, they need closer attention and maybe different management strategies.
And how can we try and prevent AOM in the first place? Any prevention tips?
Prevention really comes back to tackling those risk factors. Avoiding passive smoking is huge. Discouraging dummies or pacifiers, especially after a certain age, might help. And that point about avoiding feeding babies lying flat.
Right.
Making sure kids get their pneumococcal vaccinations is also really important, as strep pneumo was a major cause.
Okay. What about repeated antibiotics or grommets?
Repeated short courses of antibiotics might be considered sometimes for very frequent infections, but long-term daily antibiotics aren't recommended because of resistance worries. Grommets, those ventilation tubes, might reduce AOM episodes for the first 6 months or so after they're put in. It's something that can be discussed with an ENT surgeon, especially if parents are finding the recurrent infections really difficult.
Okay. And lastly, complications. We know most kids are fine, but what are the potential, although maybe rare, complications we should be aware of?
Yeah, thankfully major complications are uncommon. The most frequent thing is the eardrum perforating, which usually heals but can sometimes lead to that chronic discharge, CSOM.
Okay.
Then you have the rarer but serious ones, less than 1 in 1,000 cases maybe, things like labyrinthitis, affecting the inner ear balance, meningitis, infection around the brain, intracranial sepsis, infection inside the skull, facial nerve palsy, weakness of the face muscles.
Scary stuff, but rare. Anything else?
Yeah, the notes list a few other. Petricitis, Acute necrotic otitis, otitic hydrocephalus, various types of abscesses like subarachnoid or subdural, sigmoid sinus thrombosis, and very, very rarely systemic problems like bacteria in the blood, bacteremia, septic arthritis, or bacterial endocarditis. Again, these are very uncommon with standard AOM treatment today, but it's the full list.
Okay, wow, a lot to take in. Let's try and boil it down. What are the absolute must-remember points about AOM for our listeners? The key takeaways.
Okay, the essential nuggets for quick recall. AOM equals acute inflammation of middle ear, main causes. Bacteria, thinks strep pneumo, H flu, MCAT, and viruses, RSV, flu. Risk factors, young age, daycare, smoke exposure. Pathophysiology hinges on the eustachian tube blockage. Management, pain relief first, antibiotics selectively. Maybe think MAPLE, middle ear, acute pain relief, likely pathogens, eustachian tube, something like that.
AMEPLE. Okay, final thought then. Given how incredibly common AOM is, what's maybe the single most practical piece of advice for parents listening?
Gosh, single most. I'd probably go back to the smoking. Avoiding passive smoke exposure for kids makes such a difference for respiratory health overall, including reducing ear infections. And maybe also understanding that not every earache needs antibiotics right away, trusting the watchful waiting approach when advised.
Great advice. And for everyone listening, especially if you are revising for the MSRA, don't forget to check out passmsra.com. It's a fantastic resource.
Yeah, definitely. And there's also freemsra.com, which could be really helpful too.
Brilliant. Well, we hope this deep dive has really helped clarify acute otitis media for you. Feel free to come back and listen again whenever you need that refresher.